looking forward to our morning webinar, and we're just going to give everyone another 2 minutes or so to get logged on. So I appreciate your patience, and we look forward to our presentation today. So you are all currently muted automatically, and as you have questions, I'll be giving instructions as we continue here. So I'm going to give everyone another minute or two to get logged in, and then we'll get started. Thank you. Thank you, everyone, for joining us today. My name is Pragati Tamala, and I am the Executive Director for the International Society for the Prevention of Child Abuse and Neglect, better known as ISPCAN. Today's topic for our webinar will focus on the introduction to the medical evaluation of the child alleged to have been sexually abused. And this webinar is designed to assist participants in understanding sexual victimization of children and the issues that challenge medical practitioners when evaluating for the possibility of child sexual abuse. So before we begin today, can you please review the current slide that's going to explain a few tips for today's webinar. If you have any connectivity or audio issues with the presentation, you can contact one of our technical support staff through the chat box on your GoToWebinar toolbar that you should see on the right side of your screen. We also have in that right side an area for questions where you can type in your questions, and we will be taking those at the end of the presentation. And if you have the opportunity, we also have the handouts for today's webinar and the presentation available for you if you'd like to download that. So we're going to go ahead and get started, and I'd like to introduce to you our presenter for this month. He's one of our very own ISPCAN counselors, Dr. Martin Finkel. Dr. Finkel is a professor of pediatrics and the medical director and co-founder of the Child Abuse Research, Education, and Services Institute at the Rowan University School of Osteopathic Medicine. In 1987, he established the University Center of Excellence, which formed into the CARES Institute. In 2004, the CARES Institute was designated as a statewide resource to inform best practices in the delivery of medical and mental health diagnostic and treatment services. Dr. Finkel is an internationally recognized authority on the medical evaluation and treatment of the child allegedly sexually abused. Before we go on further, I would like to also let you know that how you can participate in the webinar. So during the presentation, everyone is going to be muted to avoid any background noise. Through the presentation, if you need or if you have questions that come to your mind, please type them into the question box, and if you have any other concerns, you can type them into the chat box. So we're going to go ahead and get started today, and I'd like to welcome Dr. Finkel and thank you all again for attending.
Great. Well, thank you, Pragati. It's my pleasure to be able to spend this time with you all, sharing some insights into the complexities of the evaluation of children alleged to have been sexually abused. I had an opportunity to see the diverse nature of individuals who are participating in the call, and it should be a diverse group of professionals because child sexual abuse, as any form of maltreatment, is a complex puzzle, and each of us has a piece of that puzzle, and in no one circumstance are we always the ordinal piece of that puzzle. So it's only through collaboration between child protection, medicine, law enforcement, mental health, education, and community will ultimately understand what a child experienced and the opportunity to substantiate concerns, which then provide an opportunity for intervention, protection, and then treatment. So,
Martin, can I quickly ask you to just share your screen so we can see the slides?
I have it on. It's up.
Is the presenter
On my screen?
Okay, now it's coming up. Sorry.
Up now?
Yeah, let's just give it 1 second to load here. Did you change the presenter to Martin? Oh, do you have 2 screens open by chance, Martin?
No, I don't think so. I have a choice of screen, screen monitor number 1.
Uh-huh.
Is that it?
That's not it. There, that's I see like a beautiful photograph.
Screen number 2.
There we go. Okay, now we're in business. Sorry about that.
I'm sorry. Okay. Anyway, so I think it's always of value to sort of understand a little bit about the historical perspective on any given issue. And, you know, for many years, all around the world, it's been said that sexual victimization of children is really an American problem. And clearly, as many of you from diverse parts of the world have discovered, it is a problem that you're confronted as well. So it's not uniquely American problem. It's a problem that is in every portion of the world. But we're all at very different stages in our development of understanding sexual victimization and recognition, intervention, and having the resources to address it. So, you know, the whole field of child maltreatment, or the issue of child maltreatment, didn't come onto medicine's radar screen until 1962. And that was as a result of the publication of the Battered Child Syndrome by C. Henry Kemp. I guess in many ways, medicine could no longer deny the reality that children were presenting to us with things that could actually be seen with our naked eyes, such as burns or implement marks, or seen through imaging. And we no longer could be so naive to think that children present with these injuries. Maybe the injuries did not occur in the manner that has been represented by individuals who they're entrusted to and have the responsibility and care for. So again, physical abuse is not a phenomenon of the 20th century, nor is sexual abuse. These are things that have been going on for time immemorial. So another outcrop of the recognition of the battered child syndrome was the development of mandatory reporting statutes. So in the United States, prior to 1962, there were no mandatory reporting statutes. Between 1962 and 1978, doctors became increasingly aware of the issue of physical maltreatment, developed much better diagnostic and perspective on these issues, and were more likely to think about the issue of physical maltreatment. In 1970, Dr. Henry Kemp published another seminal paper, and that paper was called Sexual Abuse, Another Hidden Pediatric Problem. What was interesting was that that paper fell, I think, on deaf ears. And I say that because the response to that paper was not as robust as the response by the pediatric community to the battered child syndrome. And I think that occurred for a number of reasons. And one of them is that with the issue of physical maltreatment, children were presenting with things that could actually be seen with their naked eye, either directly or through imaging. One of the dynamics of physical abuse is, of course, that at the time of the abuse, the perpetrator had some intent to cause harm to the child, physical harm. Now, they may not have intended to cause the degree of harm that they did, but the injury occurred out of frustration and anger. So when sexual abuse came onto our radar screens, in many ways, it was a very different, like I like to call, disease. And all of the knowledge and skill that doctors amassed in terms of identification of physical injuries was really not transferable to the issue of sexual victimization. So because children who are sexually abused, they are sexually abused generally by someone they know, love, and trust, and has easy access, just like in physical abuse. But a dynamic that is so different is that most perpetrators of sexual abuse have no intent to actually cause physical harm to the child because they want to repeat the activities over time. And so it requires a very different set of knowledge and skill set, both for the recognition and ultimately the diagnosis and treatment of sexual victimization. I think that there was traction to the issue of child sexual abuse in the late 70s and early 80s because of parallel developments in social work, mental health, along the lines of addressing adult rape care and recognition of that phenomenon. In 1989, the Academy of Pediatrics, for the first time, formed an interest group, a section on child abuse and neglect. Now, why isn't this? So what happens when a new disease is discovered? There's public admiration, and it's mixed with suspicion as expenditures and expectation rise simultaneously for calls for regulation and accountability. So actually here in the United States, after this society became aware and pediatricians became aware of the issue of sexual abuse, there was a lot of pushback. There was sort of the suggestion that doctors were on a witch hunt and that sexual abuse was something that we were in part fabricating, that couldn't possibly be this prevalent. But we know that sexual abuse of children is not a rare phenomenon. It's a very prominent problem. And so when I first got started in the early 80s, 1982, there was very little diagnostic criteria. There were very few people who were actually recognizing this issue. And so what happened is that those of us who occasionally saw a case were sharing information, and we sort of began the process of describing the phenomenon of sexual abuse. We had no diagnostic criteria. We didn't use the same language. We had a hard time communicating with each other, and that all over time has changed significantly. So physicians begin to conduct examinations of children alleged to have been sexually abused, motivated by our desire to understand the consequences of it, grapple with the interpretation of findings, search ways to improve the visualization, because in the early days, all we used was our naked eyes. And the tissues in young children, of course, are much smaller, they're more delicate. Some of the findings are much more subtle. And so ultimately, we introduced the use of colposcopy and the video colposcopy, which allowed us to document our findings and share our findings and talk about cases in a way that we previously could not. So we're really wading into uncharted waters. Back in those days and many parts of the world, those are uncharted waters today. But yet, today, what's different is that there's a huge body of literature and resources out there to help us address these issues if we're new to the field. I would say that medicine's contribution to the field of child sexual abuse in the early 80s was that doctors discovered that children have genitalia. And if you care to look, those genitalia are located between the belly button and the knees. Now, I know that that might sound a little bit flippant, but the truth of the matter is that doctors then and even today have genitophobia. There's this kind of uncomfortableness, this anxiety associated with looking at the genitalia of children. We need to overcome that anxiety. Genital examinations need to be a part of routine healthcare. One, because it provides an opportunity to talk about issues related to personal space and privacy, but it also gives the doctor familiarity that if they look at the genitalia, they can identify the spectrum of normal, and so that if there are changes or concerns when sexual abuse, those changes or abnormalities can be identified as well. So in the early days, really in the 80s, child protection and law enforcement were dealing with the issue of sexual abuse, but without medicine. And so what happened in the early 80s when medicine came onto the radar screen is that there began to be this collaboration. And as I said in my opening comments, these are complex puzzles, and we need the insights and perspectives of all of those disciplines. And that's why we have multidisciplinary teams. That's why we have child advocacy centers, where we bring the players together to share their piece of the puzzle. In the early days, if you were the doctor who was willing to examine the child who'd been alleged to have been sexually abused, you were the best doctor, whether you had expertise or not. And all of us are evolving our degree of expertise. So we develop, as we go on, we develop our knowledge of sexual victimizations, and we're going to talk about that a little in a moment. So the genitalia finally are placed under the microscope, and we're asking questions about what normal is, what abnormal, what is the residual to sexual contact. So if we're thinking about ultimately what is the best interest and what is the gold standard for the best interest of an investigation in allegations of sexual abuse, are we going to find it in prosecution, or are we going to find it in the therapeutic outcomes? My bias is that ultimately the best interests of children are going to be served in the medical and mental health outcomes and not in the prosecutorial outcomes. And in so many parts of the world, including the United States, so much energy is focused on legal outcomes when it should be really focused on addressing the medical and mental health outcomes, because children have to live the consequences of their victimization independent of what happens in the prosecutorial outcome. So if we're thinking about what is going to be the most available form of evidence in cases of child sexual abuse, and we look at these entities: medical history, physical examination findings, laboratory test, or forensic evidence. So in your own mind, just begin to think for a moment, what do you think is going to provide the most available form of evidence? Well, forensic evidence is present approximately 1% of the cases. Laboratory tests, such as sexually transmitted diseases, is going to be present approximately 3% of the cases. Physical examination findings that on their own are diagnostic, independent of history, of sexual contact are going to be present approximately 5% of the cases. And so over 90% of the cases, the most available form of evidence is really going to be the medical history obtained from the child. Yet the hardest thing for doctors to do is not to identify abnormal physical findings, not to make the diagnosis of sexually transmitted disease, or collect a specimen forensic evidence. The hardest thing for a doctor to do is actually to sit down with a child and take a medical history from that child that is done with empathy, non-judgmental, facilitating demeanor, that allows the child to share their experience with the doctor and allows the doctor to formulate a defensible medical opinion. So who is this man and what is his relevance to medicine? On the screen you'll see 3 money bags, and this is America's most famous bank robber, and his name is Willie Sutton. And he was asked, why do you rob banks? And when his answer to that was, because that's where the money is. And the money in the diagnosis of child sexual abuse is in fact in the medical history. But the hardest thing for us to do is to actually obtain that medical history. And so that medical history we use to integrate our physical examination findings and formulate a diagnosis. So when we think about how we ask questions, most doctors are used to asking questions in short, leading, suggestive, rapid-fire manner. And that does not allow the patient to tell, or the child to tell their wholly personal story. And so I love this quote that I want to share with you. The patient who comes to us has a story that is not told, and which is a rule no one knows of. Therapy only really begins when we understand that wholly personal story. It is the patient's secret, the rock against he is shattered. If I knew his secret story, I have the key to the treatment. The doctor's task is to find out how to gain that knowledge. The only way that we gain that knowledge is by creating an environment where a child feels safe and secure to be able to provide and share with you those details. So it's really important to think about the manner in which we obtain that verbal evidence, how we document that verbal evidence. We need to ask questions in ways that are not leading and not suggestive. We need to document both the question that we asked and the child's verbatim response. And you know what? It's not something that's so intuitively obvious as how we do this. And I learned how to do it because a prosecutor told me, you can't ask questions in the way that most doctors do, as previously stated, rapid, short-fire, leading, suggestive questions. You got to write down everything that you ask and the verbatim child's response. You can't just summarize it at the end. So I was taking a history many, many years ago in the early 80s from a 6-year-old, and I was writing feverishly, and she stopped me and said, I'm going to stop now so you can catch up. And that was the last time I asked any questions or wrote down anything from the medical history. But I took a handheld tape recorder and allowed the child to talk into the tape recorder and recorded it. And then I listened to each one of those recordings. I made a handwritten transcript verbatim, and I dictated it verbatim in the medical record. Clearly a very time-intensive effort. However, it taught me how to listen to children. It taught me how to ask questions in less leading, less suggestive ways, in ways that are more comfortable for children to respond to. I no longer do that because I've discovered that this disease has a structure to it. It's not a capricious experience for children. And all these kids, even though they're very different in their ages and the exact experiences, they all had something very similar in terms of how their victimization progressed over time. So now I use a shorthand for the words for the questions, and I write down everything the child says verbatim. So we look for historical details that demonstrate spontaneity, the statements that are elicited by questions, the idiosyncratic nature of those systems, the questions, the consistency of those statements. We look at the child's affect and emotion associated with those statements, play and gestures that collaborate the child's statements. Of course, children who have developmentally unusual sexual knowledge raise a red flag. We'll talk a little bit more about idiosyncratic details. I think that when we take this history from the child and when we do a medical evaluation, it should be the first step to therapeutic intervention for that child. And one of the things that we do in taking our history from the child is it provides us an opportunity to, in fact, address what I like to call cognitive distortions that many children have about their experiences. So if in my simple introductory comments I say, my name's Dr. Finkel and I'm a kids doctor, and one of the things I do is talk to kids every day just like you when they've been able to tell about something that happened that could be confusing or difficult to understand by someone you know and trust. That happens to a lot of kids, and I understand that happened to you. Is that true? And the child says yes. Well, what was therapeutic about that? What was therapeutic about that is that the child thought that they were the only person in the world that this happened to. They have a sense of stigmatization and shame associated with their victimization. They're now learning that they're talking to somebody who sees lots of kids just like them every day, decreasing their sense of isolation. So you'll see some images created by children seen at our institute and exhibited as an exhibit called The Art of Healing Children, very powerful images. So why do we do medical examinations when children are suspected of being sexually abused? We do them for several purposes. One purpose is diagnosis and treatment of abnormality, which would be a diagnosis and treatment of residual to sexual contact. So that would involve acute and healed genital and anal genital trauma, extragenital trauma, sexually transmitted diseases. But most importantly, we also do these examinations for the purpose of normality, the purpose of wellness, of physical intactness, to address worries or concerns about their bodies. So when I see kids, I say to kids, what today is about is to make sure your body's okay. And I want you to think about any worries or questions or concerns that you have about your body, because after we're done talking, we'll bring your parent or caretaker into the room, take a look at you from head to toe, and we can address any of those worries or concerns that you might have. And then I say, but after today, you're going to get to see what I call a talking doctor. And one little girl said, but shouldn't they be a listening doctor? And that's the connection between the medical and the mental health. So if you ask children if they have any worries or questions or concerns about their body, these are the kinds of things you might hear. A teenage girl wanted to know, she said to me, I think people can tell by the way that I walk that I had to do those disgusting things. A 10-year-old girl wanted to know if she was going to get the dying disease. I'm sorry. 10-year-old girl wanted to know if she was going to get breast cancer because this guy had put his mouth on her breast. A 9-year-old boy wanted to know if he was going to get the dying disease, AIDS. A lot of kids don't verbalize a concern, but when they have the examination and they realize that their body's okay and that nobody can tell, they have this sigh of relief. It may be a parent who thinks that their child is no longer a virgin. That's important to them. And even though the child may have no worries or concerns, this examination addresses the parental concerns as well. And of course, another purpose and a secondary purpose is prosecutorial. Everything that we do, of course, is informed, forensically informed, and therefore has a potential to contribute to the prosecutorial outcome if that's the way the case may be proceeding. So when I'm asked to testify in court, I ask the prosecutor to ask me one question. How do you make the diagnosis of child sexual abuse? And I say that I approach the diagnosis of child sexual abuse as I would approach the diagnosis of any disease. And that is that in our medical school education, we learn about the pathophysiology of diseases, the clinical expression, the development of clinical skills, taking a medical history. In fact, every one of us knows that when we go to the doctor takes a medical history. And at the end of the medical history, the doctor says, Mr. or Mrs. So-and-so, I think you have X, Y, and Z, because they've formulated a diagnostic impression based on that history. And the physical examination serves one purpose, and that's simply to either confirm the diagnostic impression or create a differential diagnosis. That model that we aptly apply to every aspect of medicine is applied to the issue of child sexual abuse if you understand the disease of sexual victimization. So, some people would suggest, particularly in the environment of child advocacy centers, that they don't want children to have to retell their story multiple times because it's inherently traumatic for the child to have to recount the story. In fact, it can be very therapeutic and should be therapeutic for kids to retell their story in the right environment with the right professional. So the history that's obtained from the doctor may be very different and have different and important details that the child may not have shared with anybody else. I wrote a commentary called I Can Tell You Because You're a Doctor. I think there's a special trust that patients and children have with doctors, so it's likely that children will share things that they may have not shared with anyone else. So when we take the medical history, we obviously want to explain to children what we're doing. We want to demystify the examination. We anticipate their fears and anxiety. We have to have a demeanor that demonstrates that we're going to have a conversation, a two-way dialogue, because when kids think that they're going to learn something from that interaction, they're more likely to share information. I already said that we have to develop rapport, and one of the ways we develop rapport is by statements such as, I talk to a lot of kids just like you every day. I ask kids, why do they decide to tell? And when you ask them that question, why do you think most kids tell? They tell because they heard about all the professionals who are knowledgeable about sexual abuse in the community? No, they tell simply because they want the abuse to stop. Find out how they feel after they told. Most kids express this amazing sense of relief because they allowed the secret to get out. Whose fault do you think it is? If you ask kids whose fault they think it is what happened to them, many of these kids actually think it's their fault. And if you ask them why do they think it's their fault, they might say, because I let him do it. I didn't stop him. I didn't tell. And that's a really important cognitive distortion to correct because children cannot consent to these activities. Their worries, their concerns, what do they want to happen now that they told? And it's a way of empowering children, giving them back some ability to have choices about their experiences. So this is the disease. It involves these stages: stage of engagement, sexual interaction, secrecy, disclosure, and suppression. So in order to have engagement, that means the perpetrator has to have access and opportunity. And who has more natural access and opportunity than a caretaker, a sibling, an uncle, a family member? And then they represent to the child the activities. They entice the child into the activities. They deceive the child into the activities. If you think of the dynamics of sexual victimization, you can think of it one way as a misrepresentation of moral standards to children. And so if a parent says that this is the way that all daddies show that they love their little daughters or sons, how's the child to know otherwise, especially when the activities are presented in a loving and caring context, where they frequently are. A colleague of mine, David Kearns, did a study in which he found that very young children who experience any physical discomfort associated with the first sexual interaction don't want to play that game again. And so it actually had protective value. So questions like this: who was the person who did something that just didn't seem okay? We don't say bad. We say wasn't okay, or was confusing to you. How do you know that individual? What were the first, subsequent, last times that something happened? So you get a second sense of the sequence of events. We try to get contextual details of the child. How often would it happen? Why did it stop, if it stopped? The activities are going to be a progressive activity over time at a variable rate, depending upon what the access and opportunity is for that perpetrator to have time with the child. The interactions are most consistent with child's developmental age. So in younger children, it's more play-like activities. The activities involve exposure, fondling, oral genital penetration. We'll talk about the different kinds of penetration in a moment. But one of the things to remember is that most perpetrators have little intent to actually cause any harm to the child. And so most kids, when they experience something that's inappropriate, are not going to have any physical discomfort, although we will talk about specific kinds of genital complaints that are in fact diagnostic in just a moment. So this is the type of sexual interactions that occur: genital exposure, observation of child, kissing, fondling, masturbation, fellatio, cunnilingus, penile penetration of vagina, digital penetration, vulvar coitus. And vulvar coitus is when objects such as a penis is placed between the labia and rubbed between the labia, perceived by the child as being inside when it does not actually penetrate in the adult sense of penetration. The legal definition in the United States of penetration is between the labia, no matter how so slight. Pornography can play an important role. In the old days, child pornography was actually used by perpetrators to normalize the activities with children. More and more, unfortunately, we're seeing child-on-child sexual victimization because more and more young teenagers are being exposed to pornography on the internet, and then what they do is they try out what they saw with individuals they have easy access and control over, such as their younger siblings, their cousins, playmates. So you might ask, why is the observation of a child, or how is that sexually abusive? There are many cases in which a child's sense of privacy is removed. Peepholes are put indoors. Doors are taken off of bathrooms. The perpetrator observes the child while bathing or stooling or toileting. All of those things, although not physically intrusive, are clearly psychologically intrusive. So if you think it's difficult to listen to this list of things that are happening to children, try listening to a 5-year-old who says, "He made me drink icky spit. He peed into my mouth." And those are exactly the kinds of idiosyncratic details that a child of that age can and often do present. So when we're talking about the sexual interaction, we ask questions such as, did the person who did this have a name for what they were doing? What was the coercion, deceit, or threats, rewards, bribery? What was the first thing the person did that just didn't seem okay, and how did that progress? We look at specific details about feelings, both in terms of general feelings, physical and emotional, discomfort associated with the contact while, during, and after, or both, sensations before and afterwards. We'll talk about that a little bit more. So when we look at idiosyncratic details, we're talking about body image concerns, age-inappropriate descriptions of sexual activities. For example, a little boy who said that he wiggled his pee-pee on my hiney and afterwards he sprinkled all over my back. And that is the description of ejaculation by a child who doesn't have the words, doesn't know the word ejaculation. We're going to talk about in a moment about post-fondling dysuria and the significance of that. Dysuria, for the non-medical people, is a term that simply means discomfort associated with urination. Post-sodomy burning is a phenomenon that reflects trauma to the mucocutaneous area of the anus following true anal penetration. And excited utterances are a legal phenomenon. In the bathroom, my dad, big, strong, nice, he rubbed my private. I felt scared. He said, "Don't tell." So once the child has experienced some form of sexual interaction, now the primary task of the perpetrator is engage secrecy, because from the perpetrator's perspective, it eliminates accountability and enables repetition. So we need to make sure that kids don't have secrets and teach kids from a preventive standpoint that it's never okay to have secrets. We can only have surprises because that means that we find out about them. And children will keep those secrets because of rewards, embarrassment, fear of punishment, abandonment, or rejection, or threats. And if you want to know what those secrets are, think of a way in asking a question without using the word secret. And I always ask the simple question, well, did the person who did that want you to tell? And the child says, no. And I ask, well, how do you know they didn't want you to tell? And they might respond by saying, well, he said that if I told, no one would ever believe me. He said if I told, I would be in a lot of trouble. He said if I told, he would do the same thing to my sister. He said if I had told, he would kill my cat. He said if I told, they would send me away. He said if I told, no one would ever love me again. And these are the kinds of statements that perpetrators will make to children. They may not make any statement, but simply their body language may clearly give a message not to tell. So we hope that kids disclose, and their basic categories: planned disclosure, accidental disclosure, and elicited disclosure. A planned disclosure is something that means that the child made a conscious decision to tell. And those are the best kinds of disclosures because it allows for planned intervention. Accidental disclosure means that neither the child nor the perpetrator were prepared to share the secret, and it always precipitates a crisis. And we are less equipped for dealing with crisis intervention than we are for planned intervention. So when a child discloses, we might ask questions like this. Most kids never tell about those kinds of things. Why did you decide to tell? Why do you want to happen now that you told? Most kids find it difficult to tell about those experiences. What made it so difficult for you? How do you feel now that you told? And most, as previously said, kids have this sense of a relief. If you could say something to the person who did that, what would you want to tell them? What would you want them to hear? And what do you think most kids simply ask? They ask the question, why? Why did you do that to me? What were you thinking? Telling is like spring cleaning. Not much fun, a lot of hard work, but it feels great when it's done. So then the perpetrator wants to suppress things, limit access, interaction, increasingly abusive threats by the perpetrator, gang up, and want to undermine the credibility of the child. Here's a teenager who carved, as you can see, the word dad and die into his arm. He was referred to me because of the concern for physical abuse. And when I spoke to him, what I learned is that the reason he was being physically abused is that he refused to do the sexual acts anymore. And so we cannot think of these things as siloed. So when we think about sexual victimization, it can occur in a context in which there's also physical abuse and emotional abuse and neglect. We need to address all those issues. Before we examine kids, we want to obtain details of the alleged event, either from a caretaker or from Child Protective Services or law enforcement. We clarify in our own mind additional information to be obtained. We develop, when we meet with the child, rapport and trust, explain the purpose of the exam, tell the child what's going to happen. We use the kid's language. We encourage children to ask questions. We assess the cooperativeness of the child. We allow the child, when it comes to the physical examination, to select the adult ally that they want present during exam, and we always do a head-to-toe examination. And the genital exam is done in the context of a head-to-toe examination because one of the messages that we want to give to children is that all parts of their body are important, not just the genitalia or anus that was the sexual activities were focused upon. So if we're thinking about immediate criteria for the examination, immediate criteria would be age-inappropriate sexual contact within 72 hours, genital trauma within 72 hours, possibility of sexually transmitted disease, or the possibility of pregnancy in a adolescent. And these are relative indications simply because within this 72 hours, there's more likelihood that you'll be able to identify any acute signs of injury. Actually, acute signs of injury can heal within that 72 to 96 hour limit. A deferred examination means that the disclosure of the age-inappropriate sexual contact occurred greater than 72 hours before, and obviously one would never do an examination in a child who was uncooperative. Sometimes children present to us and they're not emotionally ready for the examination, and the examination should be deferred. The last thing we want to do as a professional is to give the child a message that they have a right to personal safety and privacy, and we as a professional, because of our position of authority, we can force them to do something that they're not emotionally ready or comfortable to have. So this is our examination room, and what this shows you is a typical setup, and then we use Kermit the Frog here as the patient, and you can see the video colposcopy setup. Video colposcopy is obviously a tool that I think most of you are familiar with, and it allows the examiner to shine that light on the genital tissues and anal tissues and watch on a TV monitor. It allows the examiner to, of course, record this examination so that the child would never have to have another examination in the future if there is, in fact, anyone questioning the examination findings. One of the things that's so valuable about the use of video colposcopy is that the patient can actually watch the examination. It demystifies the examination for the child and gives the child a sense of participation throughout the examination, a sense of control. So as I said, we always do a head-to-toe examination. It needs to be thorough. Who is this god? This is the Greek god of Roman and mythology as well, and his name is Hymen. Hymen is the god of marriage. And actually, in the early days, it referred to a structure known as, well, the marriage veil, which was a thin membrane in a medical parlance that had to do with the peritoneum or pericardium, and it wasn't until Andreas Vesalius placed it in its current position in terms of genital structures. So these are some factoids, things that are not true but people think are true, and that is that children are born without hymens. There's no such thing as a female girl not having a hymen, except on some very unusual circumstances, such as ambiguous genitalia, distal vaginal agenesis, and transverse vaginal septum. That children lose their hymens as if it falls out. That children break their hymens as if it's a piece of china. None of that is true. Children don't lose their hymens, they don't break it, it can be injured, and there are specific circumstances in which the hymen is injured. Hymens are injured during gymnastics or horseback riding. That's total, or even bicycle riding. That's total unadulterated nonsense. You can alter the appearance of the hymen on riding a bike if, in fact, the seat comes off and the child has an impaling injury on the post, and those present with a very clear pattern of trauma. So let's move on quickly here. So this is important. When we talk to children about their sexual contact, and let's say we get to a point where we ask the child what happened next, and the child, let's say, makes a statement that he put his pee-pee in my coochie, referring to their genitalia. And when kids, and we'll talk in a moment about addressing the issue about the differentiation between in and on, but let's say the child says he put it inside, placed between the labia and And I asked, well, what did they do next? And the child might say, well, he wiggled it around. And what did that feel like when he did that? Well, it hurt. And I would ask the question, well, when kids say that it hurt, there's hurting your feelings and there's hurting your body. What kind of hurt did you experience? And the child might respond, well, it hurt both. Well, what way did it hurt your feelings? Well, it felt disgusting every time he did that. You said it hurt your body. Did it hurt your body just while he did it, or did it even bother you afterwards? Well, it hurt while he did it, and it hurt afterwards. In what way did it hurt afterwards? When I went to the bathroom to do what? To pee. What did that feel like? It burned. I asked if you ever, then I would ask, had you ever felt that before? No. Did you ever feel it again? I felt it every time he put his pee-pee into my coochie. That history that I just demonstrated to you is absolutely critical, because what it confirms with medical certainty that the child experienced genital trauma. There's no way that that child could know that symptom temporally related to that sexual contact unless they experienced such. And most of those injuries that kids occur in that context are superficial and heal. And when they present to the doctor, they're presenting without any obvious signs of injury. So we published this in Pediatrics in paper Girls Who Disclose Sexual Abuse, Urogenital Symptoms and Signs After Genital Contact. And we found that 53% of girls who experience genital contact have pain. 37% of them have dysuria, temporally related to the sexual contact. We also do a complete review of systems to make sure that there are no alternative explanations for the child's having dysuria, such as prior urinary tract infections, bubble baths, irritants, and things like that. 11% of children have had bleeding. If you want to find out about bleeding, you ask the kid not whether they had any bleeding associated with contact, but another way is to say something like, did you notice anything? You said it hurt. Did you notice anything that made you know that you were hurt? And the child might say, well, when I went to the bathroom and I wiped myself, I saw blood. So it's interesting that although 53% of children complained of genital pain with genital contact, only 17% of the caregivers were aware of that. Only 19% of the caregivers were aware of the complaint of dysuria and 4% of bleeding. So kids have these experiences, and obviously it occurs in secrecy, and if they have injuries, they don't necessarily and infrequently actually share those histories with their parents. Or if they complain or have a sign or symptom, the parent may ask about it, and the child is unlikely to say, well, it's because of X, Y, or Z, because they're told not to tell. So children will tell us that somebody's put something inside of them. And so when kids tell us that somebody's put something inside, we want to address that's a child's perception. And we want to address any discrepancies between the child's perception of what they experience and what they actually experience. In order to do that, we use this orthoanatomic model, which I'm going to show you. This is a model of the female genitalia, which every little boy, when looking at it, says, what is that, an ear? But for the girls, we'll pick it up, and I'll show them, here's where you pee, and here's where you poop. When you wipe yourself this way, from back to front when you pee, and that when you wipe yourself, when you poop, you wipe from front to back. I then explain to kids that when someone's telling me that, when kids say that somebody's put something into the private parts, there are different kinds of inside. Inside can be like this, between, like wiping, or inside can be like this, or sometimes kids are unsure whether it was this way, like wiping, or this way. And children may, with bravado, demonstrate that it went inside in their way of thinking of it. In the adult sense of penetration, that's perception, and that doesn't mean that that actually what occurred. So we do the physical examination, and then we address any discrepancy between the child's perception and what they actually occurred. And so this will help you understand a little bit better about these anatomic relationships. So here's the female genitalia in the mid-sagittal view. So here is the labia majora, the labia minora, and there's this space here. Here's the hymenal orifice, here's the vagina, here's the urethra. This is a mucosal lined area. This is known as the vaginal vestibule. It is not the vagina. The vagina begins right here. So in order for something to go into the vagina, it has to pass through the vaginal vestibule into this space, through the hymenal orifice and into the vaginal canal itself. So the hymenal membrane is the dividing structure between the internal and external genital structures. In prepubertal children, most children who experience genital-to-genital contact or genital fondling will experience penetration between the structures of the vaginal vestibule. So you can see, this is vulvar coitus. You can see how a penis can be placed between the labia, rubbed between the labia, causing trauma around the urethra, the inner aspects of the labia minora, posterior fourchette, without causing any trauma at all to the hymenal membrane. When one gets into puberty and tissues are estrogenized, there's a lot more elasticity and distensibility to the tissues, and it's a lot more difficult to be able to determine whether or not a child had penetration into the vagina or limited to the structures of the vaginal vestibule. There's this factoid that women always bleed with first intercourse, and that's how you know if they're a virgin. This study was a survey of 100 college women asking them about bleeding and pain associated with first intercourse, and 44% of girls in first intercourse had no bleeding, 56% did. So you can see that this sort of myth that bleeding is with first intercourse is in fact evidence of virginity is not true. The same thing in terms of genital to anal contact. Many times children perceive this pressure that occurs when a penis is placed between the buttocks and rubbed as being inside, but is actually penetration in between the gluteal cleft. Penetration in the adult sense would have to go through this way, and very few children, especially young children, actually experience true sodomy, true genital to anal penetration. Obviously, any genital to anal contact, any genital to genital contact is in fact abusive regardless of the depth of penetration. Now, most children who experience sexual victimization are not going to immediately disclose their sexual abuse. And so many times children will disclose long after the last contact when they feel safe. And so it's important to understand the healing of acute NA genital trauma. Obviously, if a child gives a history to suggest that the physical contact they experienced caused pain, then there's more likely to be signs of trauma. But most of those injuries are going to be superficial and heal. So we're just going to look at some, so it's important to understand the healing. Most injuries, as I said, are superficial and they heal by the process of regeneration of labile cells, and other injuries that are much more significant heal by the process of regeneration, of repair, which results in the formation of granulation tissue. So I know that this has been a little bit rushed. Let me just talk about how do we ultimately integrate all this information. Our physical examination findings, our history, laboratory tests, and forensic evidence. We have to ultimately formulate a diagnosis. And these are the basic tenets of formulating a diagnosis. We objectively state the facts. We do not exaggerate the meaning of a particular finding. We know the limitations of what we can and can't say. We do not, from a legal perspective, commingle what's called hearsay and clinician-obtained history when formulating a diagnosis. We state the limitations of our opinion. We presume our diagnosis will be challenged. And we make sure that every statement that we make as a physician is defensible and rests on sound scientific footings. We use the diagnosis section to explain and educate all that have access to the report. So we explain why evidence does not exist when the history of injury is present, why evidence does not exist when a child states that an object was placed inside of them, how a child can acquire a sexually transmitted disease without genital to genital contact. Although we didn't talk about sexually transmitted diseases, when a child contracts a sexually transmitted disease, that means that they had contact with infected genital secretions. A good example of how that can occur is a child who I had seen who was 10 years old. She described this man putting his hand down his pants into his underwear, touching his genitalia, taking his hand, placing it in her underwear, fondling her, and he transmitted to her HFG, herpes simplex virus, and she got HPV infection. She never saw his genitalia, and there was no genital to genital contact. So here are the basic categories or scenarios. The medical history and behaviors are clear and descriptive of inappropriate sexual contact, but no physical evidence is present. Medical history and behaviors are clear and descriptive of inappropriate sexual contact with symptom-specific complaints reflective of genital or anal trauma, and that's the post-dysuria, fondling dysuria, and post-anal anal penetration, anodynia. The medical history and behaviors are clear and descriptive of inappropriate sexual contact, and physically diagnostic residual is present, and that would be a child who presents with acute or healed injuries such as transections of the hymen, a sexually transmitted disease, or other physical forensic evidence. You'll see in the handout, which I'd like you to refer to in your own time, the other less common scenarios, but these were the most common scenarios that we have. I know that this has been sort of a maybe too fast and lightning overview of some of the essential elements of making the diagnosis of child sexual abuse. I think that I'm going to open us up now for questions in these last 5 minutes that we have. Thank you for your attention.
Thank you so much, Martin. It was extremely informative. We do have a question, several. The first is, in resource-poor settings where the availability of child protection services are scarce or not available at all, the identification of sexual abuse causes a moral burden on the health professionals who sometimes can feel very guilty about not being able to help the victim and letting the victim go untreated. Do you have any guidance or any suggestions as to what they could do to address the issue?
I think that's a very good question, and I understand what a challenge that can present. It's almost like, you know, screening for cancer when we have no treatment for the cancer. I think the bottom line is I think you have to do the best job that you can. There is considerable variability in the access to resources, whether it's child protection, law enforcement, medicine, or mental health. And you have to make an assessment of what resources are available to you. And yes, there may not be formal systems of child protection, but a child is brave enough to disclose, you were able to hear, you were able to validate their experiences, you will take steps and help a parent take steps to ensure the safety and security of that child as best you can within that context. And then identify those mental health services, clinical services that might be available to help the child process their experience the best as you can. In some parts of the world, there are lay people who are providing mental health services, because in some parts of the world, there are no psychologists or master's level people. So there are a lot of things available in the literature and available to professionals throughout the world that can help them increase their skills and do the best job that they possibly can.
Right.
We're all in stages of development.
Right. Okay. Another question is, when children are not emotionally ready for the exam, is there any guidance you would have on how to prepare or counsel them in the time that you do have face-to-face with them? How do you maximize that time you have to try to get them to that next stage of being ready to talk?
So many times kids are comfortable talking about the experience that they had with you, but they may not be ready to have their private parts looked at. And that's most commonly the experience I have, particularly in teenagers. And it's just that they've been through so much, and many of those teenagers who are presenting again long after the last time, so that from a strictly medical perspective, it may not be necessary to do that physical examination at that moment in time. And so kids will express their anxiety about or embarrassment to have their private parts looked at. And what I try to educate kids is why there would be value to them to have this thing done. Why would it be of value for them to have a doctor take a look at their private parts? And that I have to demonstrate to them that I acknowledge and respect their desire not to have the examination done at that particular time. If they understand why the examination can be helpful to them. And it's on their terms as to when it will be done. My experience is that these resistant children will come back after they see the listening doctor and have processed a lot of the emotional issues surrounding their experiences and say, I'm ready now to have my examination. And I'm amazed. I would say over 90% of kids have been reluctant to have it at the time when they're presenting, say to the listening doctor, I think I'm ready now, and are cooperative for the examination and find the examination of value because they really want to know whether or not their body is fine, whether people can tell if there's a difference. It's an important piece of their sense of well-being, physical intactness.
Right. Yeah, great advice. So another question we have is with children who have other disabilities. A lot of times we find children with disabilities tend to be even more vulnerable to this type of abuse. Would you take any other, additional approaches, or would you have to do anything, else to be able to treat or examine children with disabilities?
Well, clearly, every child is different. And children with disabilities present unique sets of challenges. I mean, we see children with on the autism spectrum, and one might think that it's hard to communicate with children with autism. But you know what? They're all different, and they all have feelings and anxieties and fears. And there's a lot that we can do in changing our communication style if we understand that disability and the limitations of it. I'm always amazed how cooperative kids with disabilities can be if you anticipate their fears and anxieties and demonstrate time, patience, empathy, caring, and kids will be able to tell you things that you would be surprised that they could tell you.
Okay. And then when you have to do physical examinations and or recording sessions where you're doing the physical camera and examination of the child, does this always require parental consent? And what if the parent is the perpetrator and refuses? Is there a way around that physicians should be aware of?
Well, the alleged perpetrator is never present when we're evaluating children for the issues of child sexual abuse. And in the United States, we do not need parental consent to identify and to preserve physical evidence as a part of an investigation. Now, we always explain to parents that the examination, the non-offending parent or caretaker who's with the child, that the purpose of recording the examination is two purposes. One, as I previously mentioned, if our opinions are challenged, then the child does not have to undergo another examination. We also will record the examination in circumstances in which the child is at high risk and we're not necessarily going to be able to have sound protection. We want to establish a baseline because if there are concerns in the future, then we have some reference point for the future, and hopefully there won't be any concerns in the future.
Okay, so I have two more questions, and I know we're a little bit over time, so thank you for your patience, everyone. One more question is, when physicians are used for prosecutorial purposes versus just therapeutic, for instance, if justice system wants the pediatrician to just do the examination for prosecutory, type of circumstance, does the doctor have any recourse if they want to continue to follow the patient beyond that one examination?
So here in the United States, I think that we have specialty of child abuse pediatrician, but when we do examinations, if you were to read my report, the very first line of my report is, the purpose of today's examination is to diagnose and treat any residuals of the concern that they were touched in a sexually inappropriate manner. The operative words in which I function are diagnosis and treatment. I am a pediatrician who is there to address the medical concerns about this child, not to address any prosecutorial issues. But as I previously said, everything I do is in fact forensically informed and has the potential to have investigatory and forensic value. But my role as a pediatrician is to address the therapeutic needs of the child and not to address and focus on the law enforcement needs and outcomes.
Okay. Um, and then last question, and then I think we're going to have to wrap it up, but our recording as well as the handouts will be available after the session. So the last question is the definition of physical sexual abuse the same in every country?
No, it is not. And so I don't know, there's a spectrum of the definition. But I think that if you think about sexual victimization, there is a common thread and theme in terms of the definition. One of the things I want to say is that there is no direct correlation between the degree of physical intrusiveness and psychological intrusiveness. And we see children who have been touched on their breast, let's say an adolescent girl is touched on her breast, over her clothing by her father, which the child will be devastated by that because of their invasion of privacy, their sense of betrayal, the issue of trust. And then we see children who experience much more intrusive physical acts that in fact have amazing resiliency. So I think that any invasion of personal space and privacy in fact, has the potential to have psychological impact. And so it's not the depth of penetration, it's not the full, you don't have to have X, Y, or Z to have some invasion of privacy, something that is sexually inappropriate with a child.
Yes. Great points, and we just thank you tremendously for your time and this really informative session today. It's an uncomfortable topic, but one I think that is so critically relevant for us to understand and be able to support children who've been through this type of trauma. So thank you very much, Martin. We appreciate your time.
My pleasure. And I think on the last slide is my email address. If anyone has an issue, cares to reach out to me, that I can be of help, it'd be my pleasure.
Great.
Thank you.
Thank you. And for all of our participants today, again, the handouts are available on the right-hand side of your column. The recording will be available within 48 hours on our ISPCAN.org website. So we encourage you to continue to visit us. And if you're not a member, please join us and become a member of ISPCAN. So thank you all today. We appreciate your time, and we look forward to seeing you on one of our next webinar sessions. Have a great day.